everyone, and welcome to the new YouTube channel that is MedBites. Well, I'm Dr. Preeti Sharma, and I'm a pathology educator on the platform of Unacademy. With me, I have the honor of having joined us today, Dr. Dilip. And sir, a brief introduction. I'm sure everyone already knows you, but a brief introduction from your end also would be great.
Thank you so much, madam. And I think we are coming up with a new YouTube channel in the name of MedBites, and we are going to discuss a few important topics so that it may be useful for you guys. And I think we can move into the session.
Right. So while on this channel, we'll be having a lot of classes and sessions where you'll be told about clinical cases along with all the updates and recent advances that have come up. But to begin with, sir and myself, we've come up with a particular case which is MCQ based. So I guess we can start with the MCQ first, and then we'll try to integrate both the subjects and we'll come to a common conclusion, and we can go in a manner of how we assess a patient and treat a patient finally. So I think, sir, we can project the MCQ for the students so that they can also attempt first.
Yes.
And then let's take up the discussion.
Yeah, you're reading out the question, madam, or I should read out?
Yes, sir. So there's a patient who presents to his primary care physician with complaints of regular headache and upper abdominal pain. On physical examination, the spleen and liver seem enlarged and his face is plethoric. Gastroendoscopy reveals gastric ulcers. The size is mentioned. There's a bone marrow aspirate which shows hypercellularity with fibrosis, and serum EPO levels have come out to be low. The patient is informed about a new treatment, a new drug that has been given to him, and for all his symptoms that are there. Which of the following conditions below can develop due to the same mutation that is causing this patient's symptoms? So whatever disease you feel and whatever mutation you can gather out of it, you need to pick up another disease which could carry the same mutation. And I think most of the students by now would have been able to guess that this is probably a case of polycythemia vera. And sharing a common mutation with polycythemia vera is the option number D, that is essential thrombocythemia. So the mutation that obviously we are talking about is the JAK2V617F mutation, the one that is very famous for these chronic myeloproliferative neoplasms. So if we move ahead, and I think sir would obviously be the best person to tell us about the symptoms. I'll just brief everyone about the criteria that we follow. First, we'll talk about polycythemia vera, which is the one that we need to discuss. The question is on that. So, sir, there's a table in the upcoming slides which is regarding the criteria. Yes, and there are obviously, as everyone can see, there are 3 major criteria and 1 minor criteria mentioned out here. So the first major criteria, now when we're talking about polycythemia, primarily it's an increase in the hemoglobin. So the cutoff for males, hemoglobin more than 16.5 and females more than 16. Apart from hemoglobin, we also seem to analyze the hematocrit. So hemoglobin into 3, we somewhere get the hematocrit. So more than 49 in men, 48 in women. And the third thing that we can analyze is an RBC mass. So for when we analyze the RBC mass, we always take it as a 25% increase from the normal predicted value. So the first criteria revolves everywhere around the hemoglobin. And yes, 16.5 and 16 are the current values. Earlier, they used to be 18 and above. So obviously that has changed. Now we follow 16.5 and 16. That's the first major criteria. The second one is a very pure pathology criteria where we take into account the bone marrow morphology. And as the word says, there is pan-myelosis. Now, pan-myelosis means everything. Everything in the marrow is going to go up. Everything meaning the red blood cells, the white blood cells, the platelet precursors. So everything in the marrow is proliferating. We call it pan-myelosis. And that is why the first word, the marrow will be hypercellular. And that is something which is written in your question also. Your question clearly mentioned that the patient had a hypercellular bone marrow. So that is again something that comes in the criteria. The third one, which is obviously one of the most important ones, is the JAK2V617F mutation, which we see in almost 95% of the patients. The other ones can also show a mutation in JAK, which is exon 12. So most common is the V617F. Then we have the exon 12 mutation, which is the remaining cases. So these 3 make up your major criteria. And there's one minor criteria, which sounds minor, but Sir would also be explaining in a while that it's actually a very important one, that the erythropoietin levels seem to be or have to be either normal or below normal. So that's why they've used the word subnormal out here. Basically, the EPO levels cannot be elevated because then we are considering other causes of polycythemia or other causes of increase in hemoglobin that can happen when the EPO levels are up. So here we have this set of criteria which more or less was fulfilled. So when we come back to the question, maybe this is not exactly what they had given you word by word, but certainly they had given you symptoms around it. So here your patient was, having headaches. Your patient had a plethoric face, coloration of the face because of the increase in the hemoglobin levels, hypertension, dizziness. These are the kind of things which are mentioned when they want to tell you that the red blood cells are increased. When the white blood cells, and particularly when they say white blood cells are increased, they really emphasize a lot on the basophils and the mast cells. Now we know that basophils and mast cells are very, very rich sources of histamine. So there's a very famous term that also comes in the AIIMS exam, and that is aquagenic pruritus. INI-CT is quite fond of this question. Aquagenic pruritus is like that we've depicted in a picture also out here. After a hot water bath, patient is going to complain of intense itching. And why after a hot water bath? Because as sir has mentioned, the histamine release. The release of histamine from basophils and mast cells after a hot water bath is going to cause this pruritus. So that is one very important history given. And as I told you, everything is increasing, right? So RBC has increased, WBC has increased, and so have the platelets. So what happens when the platelets are increasing, the megakaryocytes, there's a condition known as erythromelalgia. What is erythromelalgia? The picture again depicts. Patient classically tends to tell you about burning sensation and throbbing pain in his fingers, in his hands and feet. So throbbing pain and burning sensation, that is something indicating us towards erythromelalgia. So when this kind of a cumulative history comes to us, at least these are some of your main catch points which help you go in favor of polycythemia vera. And obviously the mutation then helps us. So sir, I think the briefing of it in the best way that I could, I have helped students with, but I guess sir has a lot of other things to add on to this from medicine point of view. So I think sir should take it up from here.
And we didn't actually tell about how to make a diagnosis based on this major and minor criteria. So you should have at least all three major criteria, or you can have the first two major criteria and the remaining minor criteria. So based on this, you will be able to make a diagnosis of polycythemia vera. So all three major, or you can have the first two major plus one minor criteria, that is subnormal erythropoietin. So if you have this, probably you can make a diagnosis of polycythemia vera. And apart from that, like you get the symptoms right, but what is the most important complication that tends to happen in the setting of polycythemia? It's thromboembolism, thromboembolic manifestations. And second, they can bleed. So these are the two important things that you need to know. So in the sense, polycythemia patients are not just clotters, which means they are not just going to produce thromboembolic manifestations, they're also going to bleed. They're also bleeders. That's pretty much important. And to be honest, whatever symptoms that we have discussed so far, including the increased RBCs, WBCs, platelets, along with the clotting, bleeding tendencies, all these manifestations can be seen even in patients with essential thrombocythemia. So technically, what is the important risk factor for thromboembolic manifestations? In fact, most of the morbidity and mortality in patients with polycythemia are going to be because of thromboembolic features. So what will be the risk factor, most important risk factor? To be honest, increased WBC surprisingly correlates with the thromboembolic manifestations rather than the increased RBCs. This is something that has been proven in a lot of trials. This is true even in patients with essential thrombocythemia. Even essential thrombocythemia, when you have more WBCs, the risk of getting thromboembolic manifestations is quite high. And at the same time, you also need to know that what are the sites of thromboembolism? That could give a clue. So in patients with myeloproliferative disorders, especially conditions like polycythemia vera or essential thrombocythemia, you tend to get thromboembolism in both arterial circulation as well as venous circulation. This is quite important and interesting as well, because in most situations, you tend to get predominantly venous thromboembolism by virtue of triad. But MPDs, your myeloproliferative disorders, are one important groups of disorders which can produce both arterial as well as venous thromboembolism. So that's quite a very important and interesting point. And which areas are particularly prone for thrombosis? Even that could be a question, especially abdominal thrombosis. When you have thrombosis in the abdominal circulation, like if you get mesenteric thrombosis, or if you get portal vein thrombosis, or if you get Budd-Chiari syndrome, that's hepatic vein thrombosis, that is quite specific for your myeloproliferative disorders. On top of that, patients can get cortical venous thrombosis as well in the brain. So that's not quite specific, but when you get abdominal thrombosis, like mesenteric, portal vein, or Budd-Chiari syndrome, always think about one of the two possibilities. When it comes to hematology, you're going to think about myeloproliferative disorders or even PNH. PNH also tends to produce more of abdominal thrombosis. And what about bleeding? So many people think that increased platelets means you're going to result in thrombosis. That's okay to some extent, but to be honest, these are dysfunctional platelets. These are not actually normal platelets. That's the reason why platelet count of more than 1 million is thought to increase the risk of bleeding. This is again quite interesting, isn't it? So these are two things that you don't expect normally. So increased WBC is actually increased the risk of thromboembolic manifestations, and increased platelets is going to increase the risk of bleeding. That is why these are going to be examiner favorites, because these are something that you don't really expect to happen. That's the main reason. And so these are the two things I felt that I have to fill it up.
Yes, sir. So I guess we can, sir, first get back to the question and just help the students analyze where we've reached in terms of that. So like sir has told us about all the complications and the entire criteria, we finally made a diagnosis based on the questions. So if you see, you had a patient who had headache, you had a patient with upper abdominal pain, gastric ulcers is also something that is seen in them. And the bone marrow has shown us hypercellularity. That was something which was there in the major criteria, right? Bone marrow showed us pan-myelosis. And see, the minor criteria is also out here. The serum erythropoietin level mentioned is low. Now going forward, when you think it's a case of polycythemia vera, you know that the mutation is JAK2, which you're expecting. So they asked you which other condition, and the other condition, like sir was saying, clinically also is very similar at times. So is it similar mutation? So that seems to be essential thrombocythemia. So if you look at the word thrombocythemia, you understand that the platelet count is going to be more over here. The minimum cutoff being given as 4.5 lakhs, but obviously the count out here is much more. That's just a minimum cutoff of 4.5 lakh that they say. So yes, the platelet count is more, and if the platelet count is more, this means somewhere the precursors are doing a lot more work. The precursors in the bone marrow are what? Of the platelets, they are the megakaryocytes. So there's a very famous terminology which is used in essential thrombocythemia. So I guess we can get to the picture of the STAG1, which I guess is an all-time student's and a pathologist's favorite image to test a student. So this typical STAG1 is something known as a STAG1 megakaryocyte. So when I say STAG1, it obviously reminds you like the horns of a stag or a deer. And this cell that is shown on his head, this entire big cell that we have, that's a megakaryocyte. So if you look at the blue color nuclei, they all look like the horns of a deer, the horns of a stag. So this entire big cell on his head, this entire thing is a STAG1 megakaryocyte, which you see in ET, in essential thrombocythemia. And as soon as I say the word STAG1, in pathology, there is it's like, you know, I open up so many questions that come with the same term, and they act as buzzwords for so many other MCQs as well. So when I use the word STAG1, I'm just going to change the second word now. I think this is a picture which is quite characteristic, and everyone knows. You can see the specimen of kidney in front of you, and you can see the beautiful STAG1 calculus embedded in it. So this is another term, a STAG1 stone, a STAG1 calculus. And the questions that you particularly get with regard to medicine and surgery out here is the composition of the STAG1 calculus, which happens to be the triple phosphate. It's a triple phosphate stone, also known as the struvite stone. So this is something which you are asked in path and surgery, any subject you wish to put it under. So it's a triple phosphate struvite stone, and there's one particular infection in microbiology with which they relate to this particular stone, and that's the Proteus infection. So yes, Proteus has been linked to the STAG1 calculus. So that's the second one. First you did was a STAG1 megakaryocyte in ET. The second that you've done, yes, urease positive organism Proteus, that is STAG1 calculus. Then we move on to the next tag-on, which is going to take us again into core pathology. So this is actually FNAC of breast. This is an FNAC that has been done from a breast lump, a young female, 20-year-old female breast lump. And this FNAC, the outline of that entire cluster is like a stag horn. So that's a fibroadenoma. Fibroadenoma shows us stag horn clusters on FNAC. Remember, this is not a biopsy thing. This is the needling technique. This is the FNAC of the breast that has been done. And this is fibroadenoma. Again, a very, very famous buzzword. So if breast is written, you know FA is the answer. And finally, one of the last stag horns that we have, which is again a core pathology finding. If you look at those spaces, all those weird shaped spaces that you're seeing out here, all these are blood vessels. So what do we have out here? We have stag horn blood vessels. All of these white spaces that you're seeing, they have these random weird horn kind of shapes, right? So these are the stag horn blood vessels. And then as soon as I say that, which is a tumor that we're talking about, it's a malignant tumor called hemangiopericytoma. So stag horn blood vessels, you see this picture, you see this term written, and the tumor is hemangiopericytoma. So that is what you need out here. Yes, having said that, so these are the 4 stag horns that we had to know, and obviously away from ET, but I guess something that we had to link. Anything, sir, anywhere that you wish to add, obviously, please do tell us with the knowledge. Anything you want to add anywhere, please do.
So I think the only thing that is left so far is the treatment of polycythemia. The other things I think we have covered already. And what could be the treatment? So all patients is going to receive definitely aspirin. Everyone should receive aspirin. There's no doubt about that, because there is an extremely high risk of thromboembolism in patients with polycythemia. And all patients will be receiving phlebotomy as well. That is to reduce the burden of hemoglobin and hematocrit. And plus or minus, you have to give allopurinol, because there is increased cell turnover in the setting of polycythemia, any myeloproliferative disorder for that matters. And there is high risk of hyperuricemia and gout. That's why optionally, if you have high uric acid, probably you can go for allopurinol. And plus or minus, you can use high dose antihistaminics. That is because of the histamine release causing aquagenic pruritus. If that is the major issue, then you can add antihistaminics as well. So this is true for all patients. This is not just for one particular group of individuals. This is for everyone. Going to use this treatment for everyone, all patients. Aspirin for everyone, phlebotomy for everyone, allopurinol optional, antihistaminics optional. So what could be the target in exam will be the phlebotomy goals. So what are going to be the goals of phlebotomy? What should be the target hematocrit? So if it's going to be a male, your target will be less than 45%. If it's going to be a female, your target will be less than 42%. Or in case if they specify about a pregnant female, then the target will be less than 37%. So I would feel that in case if they don't specify anything, then you can use this as overall target, because the minimum hematocrit that you have to achieve is at least 45% and less, and should not be more than that. So this will be the single best answer if they don't specify any gender or a particular situation about pregnancy. In case if the patient belongs to a high risk category, in case, apart from this common treatment, in case the patient belongs to high risk category, you need to add hydroxyurea. You need to add hydroxyurea. So what do you mean by high risk? Age more than 60, number one, elderly individuals, and those with history of thrombosis. In that, if they ask you what is the most important risk factor for thrombosis, it's going to be the history of thrombosis. More than the age, the history of thrombosis is going to be the most important. So if any one of these high risk features are there, then probably you can proceed with hydroxyurea. So in case if the patient is not tolerating hydroxyurea, then alternative treatment to that will be ruxolitinib. Alternative to hydroxyurea will be ruxolitinib. We know what is ruxolitinib. It's a non-selective JAK1/2 inhibitor. We have more selective JAK2 inhibitors, which is predominantly used primary myelofibrosis sometimes, but ruxolitinib will be the key drug in patients with polycythemia vera. It's an alternative to hydroxyurea. So remember, both ruxolitinib as well as hydroxyurea is actually contraindicated in setting of pregnancy. You cannot use it. So in case if they specify about a pregnant female who's having polycythemia vera, then your treatment of choice will be interferons. In case if you want to use treatment, you can use interferons. But interferons are again contraindicated in patients with thyroid disorders and depression, so you can't use that. But overall, So only 3 drugs I want to mention, specify again. First choice, apart from phlebotomy, is going to be your hydroxyurea. Alternative to hydroxyurea will be ruxolitinib in case if the patient doesn't tolerate it. Then in case if they specify about a pregnant woman, then you can't use both of these drugs, then the treatment of choice will be interferons for that matters. And I think that completes the discussion on polycythemia vera. Anything you want to add up, madam?
Right. So I think that pretty much sums up everything. And as we had discussed each and every symptom point by point, I think the treatment has just gone well with every symptom that we discussed. We've discovered or we've got a drug which we're dealing with. So I think we integrated it. So I think we've wrapped it up, and sir has beautifully just summed up the entire treatment part and wrapped up polycythemia vera for us. So I think we can wrap up the session also, and I hope all of you have enjoyed this session. And if you want further more discussions of different subjects, do let us know your feedback, any particular topic that you guys are looking out for. Do mention that in the comments below. Obviously, leave us a like and a subscribe if you feel that it was worth it. And we'll obviously try and take into account whatever feedback you give, and we'll try to get in more topics for all of you. So thank you, sir, so much for teaching me so much of medicine related to polycythemia vera, and I think I'm taking back a lot of knowledge. I hope the students are also.
Thank you so much, madam. I think this is the first time I've heard about the different types of stagons in pathology. I think you have beautifully summarized, and this is how students should learn actually. So just go around a topic and try to learn everything about a topic. That's what madam is trying to exactly do. And that's a beautiful way of teaching on how to go about a topic and how to take things like in parallel with one particular topic. And we are hoping to do much more sessions like this in the same channel. And if you have any doubts or if you have any queries, you can just post your comments below. And with it, I think we can wrap up the session. And again, once again, thank you very much, madam, for teaching me a lot of pathology as well. And actually kind of rekindled my interest in pathology as well, to study more about pathology.
Thank you. Thank you so much, sir. And thank you to all the students for listening us out. Study well. Have a great day.